In this video, we shall be discussing regarding the pharmacotherapy of gout. Gout may be defined as a crystal-induced arthropathy characterized by the deposition of monosodium urate monohydrate crystals in and around the joints. Monosodium urate monohydrate is a derivative of uric acid. In general, gout is more common in males. Now, uric acid is the end product of purine breakdown, and uric acid is ultimately excreted in the urine. For reasons which are still under investigation, certain individuals tend to under-excrete uric acid or overproduce uric acid. The result is an increase in plasma uric acid, and when this exceeds a level of 6.8 mg per deciliter, the plasma gets supersaturated with uric acid and the patient becomes predisposed to formation of crystals of monosodium urate monohydrate. Right. Now, it helps to brush up our knowledge regarding purine metabolism. It goes a long way in clarifying the concepts that we are about to discuss. Right, so we know that purines include adenine and guanine, and together with the pyrimidines, we know that this forms the nitrogenous bases. Of course, the pyrimidines include cytosine, uracil, and thymine. We know that bases combine with sugars to give nucleosides, and we know that bases combine with sugars and phosphates to give nucleotides. We also know that polymers of nucleotides are called nucleic acids. Right, so the sugars that we can combine with the bases include ribose and deoxyribose. When ribose is added to the respective bases, the terminology changes to give the respective nucleosides. For example, when we add ribose to adenine, we get adenosine. When ribose is added to guanine, we get guanosine. Addition of ribose to cytosine gives cytidine. Addition of ribose to uracil gives uridine. And addition of ribose to thymine gives thymidine. The addition of deoxyribose to the respective bases give nucleosides of the corresponding names. Now, once we add 1, 2, or 3 phosphate molecules to the nucleosides, we get monophosphates, diphosphates, and triphosphates respectively. So accordingly, we get these nucleotides. Right, we discussed that polymers of nucleotides give nucleic acids. And if the nucleic acid that we are talking about is DNA, then the nucleotides which are important become these particular nucleotides. Right. So let us take a look at a schematic representation of a nucleotide. So this would be a base, the sugar, and the phosphate molecule. The nucleotide has got a 5' end and a 3' end. Now, we said that nucleotides polymerize with each other to form nucleic acids. Let us now try to synthesize a nucleic acid. So this would be a nucleotide. When we want to add the next nucleotide to this particular nucleotide to synthesize a polymer, the incoming nucleotide would be added to the 3' end of the previous nucleotide. So let's see how that happens. So here's the incoming nucleotide, and as you can see, it is being added to the 3' end of the previous nucleotide. And the same thing happens with the next incoming nucleotide. So in this manner, the nucleotides get added to the preceding nucleotide and the nucleic acid is formed. Now we know that DNA is a double strand, so we need to synthesize the complementary strand to this particular strand. and it should be synthesized in the anti-parallel manner. So here's a nucleotide. The incoming nucleotide should be added to the 3' end of the preceding nucleotide. So there you go. And here's the next nucleotide. Now we know, as per the base pairing principle, adenine should pair with thymine and guanine should pair with cytosine. And that's exactly how it happens. So this is a very rudimentary discussion regarding how purines and the nitrogenous bases are involved in the synthesis of nucleic acids. Now, we need to have an understanding about how purines are synthesized and ultimately broken down. This clarifies our knowledge regarding the drugs used in the pharmacotherapy of gout. The synthesis of purine nucleotides begins with a pre-existing nucleotide, ATP. ATP will combine with ribose 5-phosphate produced by the HMP shunt pathway, the hexose monophosphate pathway. These combine to give a compound known as phosphoribosyl pyrophosphate, and PRPP is going to undergo multiple steps, which we shall conveniently leave out in this particular discussion. When we have subsequent discussions, separate discussions on drugs such as methotrexate, we would have to go into these steps in far greater detail. But for now, let us skip these steps. Right, so PRPP undergoes multiple steps to give IMP. And IMP will give our purine nucleotides, namely AMP and GMP. During the formation of GMP, an intermediate nucleotide known as XMP, xanthosine monophosphate, is formed. Now, if you take a look at AMP now, the addition of 2 phosphate molecules to AMP gives ATP, and this can be used in the synthesis of RNA. But if we want to incorporate ATP into DNA, we should first convert it to deoxy ATP, and this is possible with the help of an enzyme known as ribonucleotide reductase. Similarly, GMP can be converted to GTP, which is incorporated into RNA, and GTP can be converted to deoxy GTP with the help of ribonucleotide reductase again. And this can subsequently be used for the formation of DNA. So this is how purines are incorporated into nucleic acids. Now, we need to know how these purines are broken down. AMP gets broken down into adenosine. Adenosine together with IMP gets broken down into inosine. Meanwhile, adenosine can also be broken down into adenine. Right. So inosine proceeds to get broken down to hypoxanthine, and hypoxanthine gets broken down to xanthine. Meanwhile, GMP gets broken down to guanosine and subsequently to guanine, which then gets converted to xanthine. Xanthine is then converted to the end product of purine catabolism, of purine breakdown, and that is none other than uric acid. Uric acid is then unceremoniously thrown out of the body through urine. Right, now there is an enzyme that is responsible for the conversion of hypoxanthine to xanthine and then the conversion of xanthine to uric acid. The name of that enzyme is xanthine oxidase. Now, while we are discussing the metabolism of purines, we can just make a mention regarding the salvage pathway. Now, what is that? In situations where we need a little bit more nucleotides and we do not want nucleotides to be wasted through urine, we need to salvage these nucleotides. We need to save it from being wasted through the urine. So there are pathways for this indicated by the thick blue lines, which we call the salvage pathway. We salvage nucleotides and prevent them from being wasted in the urine. That's what we mean by salvage. There are other pathways by which we can salvage nucleotides. This is one particular pathway. Alright, now uric acid can be converted to a structure known as allantoin. Now this doesn't occur in human beings, it occurs in all other mammals. Human beings lack the enzyme which is responsible for the conversion of uric acid to allantoin, and this enzyme is urate oxidase, otherwise called uricase. Right. Now, as we discussed earlier, certain individuals, due to reasons which are still under investigation, certain individuals either under-excrete or overproduce uric acid, leading to the excessive levels of uric acid in the plasma, and when it exceeds 6.8 milligrams per deciliter, the plasma gets supersaturated with uric acid and the patient starts precipitating monosodium urate monohydrate crystals, and these get deposited in the joints. Now, this is going to provoke an inflammatory reaction, and let us see how. Macrophages will start phagocytosing these monosodium urate crystals, and when they do so, they release interleukin-1 beta, which is pro-inflammatory in nature. The deposition of monosodium urate monohydrate crystals in the joints also activate the complement. The activation of complement will cause chemotaxis of neutrophils. The neutrophils will also phagocytose the monosodium urate monohydrate crystals, but in doing so they undergo lysis. And when they undergo lysis, they release a large number of lysosomal enzymes, and these also contribute to joint inflammation. As we shall see later, there are drugs which target the activity of the neutrophils, drugs which inhibit the chemotaxis of neutrophils and the release of pro-inflammatory substances by the neutrophils. The drug we are talking about is colchicine, and we shall see a lot more about colchicine in the later slides. Now, it is true that hyperuricemia is a prerequisite for gout, but we need to understand and remember that hyperuricemia alone is not equal to gout. In fact, the plasma uric acid may be normal or even low if measured during an acute attack of gout, and there may be two reasons for this. Firstly, the inflammatory cytokines released during an acute attack of gout can actually increase the urinary excretion of uric acid. In other words, inflammatory cytokines can have a uricosuric effect. Another reason which explains why serum uric acids may be normal or even low during an acute attack of gout is the initiation of urate-lowering therapy. We will see a lot more about urate-lowering therapy in the coming slides. So these are two reasons which explain why uric acid levels may actually be normal or even low during an acute attack of gout. Right. Now, is it important for a beginner to know how to establish a diagnosis of gout? Well, it is. In various academic settings, questions are asked in the form of clinical scenarios, and it is important to be able to identify the situation and make a diagnosis. Fortunately, it is quite easy to make a presumptive diagnosis of gout. The clinical features strongly suggest a diagnosis. In up to 90% of first ever attacks of gout, we have monoarticular involvement, that is, only a single joint is involved. The patient is going to complain of excruciating pain And in most cases, that joint will be the first metatarsophalangeal joint, the great toe. Swelling of the great toe in these sort of cases is called a podagra. The joint will be seen as highly edematous and erythematous. Now again, we need to remember that not all podagra is caused by gout. It could very well be a septic arthritis or something else. So how do you arrive at a definitive diagnosis of gout? We need to aspirate the joint and examine the specimen under compensated polarized light microscopy. If we are able to identify needle-shaped crystals which show negative birefringence, then the definitive diagnosis of gout may be established. It's worth noting that instead of needle-shaped crystals, if we were to find rhomboid-shaped crystals which show positive birefringence, then we need to change our diagnosis and make it a diagnosis of pseudo-gout. As a side note, chondrocalcinosis is something that is commonly seen in pseudo-gout. More about that later. Right, so we need to know about the morphological changes in gout. Initially, we can have acute arthritic gout, which we saw in the previous slides. But if this is poorly treated or left untreated, if the patient is allowed to suffer from repeated attacks of acute gout, then in the coming years, the patient will progress to a stage of chronic tophaceous arthritis. Now, this is characterized by fibrous or bony ankylosis and can interfere with joint function. Now, tophi is a word that we see commonly when we read about gout. We do not see tophi in the initial stages of acute gout. Tophi are formed when gout is left untreated for many years. So what is a tophus? A tophus is singular and tophi is plural. So what's a tophus? Firstly, a tophus is pathognomonic of gout. It establishes the diagnosis. A tophus may be defined as large aggregates of monosodium urate monohydrate crystals surrounded by an intense inflammatory reaction of foreign body giant cells. So again, tophi are pathognomonic of gout. They are not seen in the initial stages of gout, but is seen only when gout is left untreated and is allowed to progress for many years. Another clinical feature which is seen in patients with gout, not in all patients of gout, but in some patients with gout, is gouty nephropathy. So this is the entire clinical spectrum that we may see in a patient with gout over the years. Yeah. So how do we manage gout? The management of gout involves a management of the acute attack of gout and long-term management of gout. Acute management of gout involves the use of colchicine, non-steroidal anti-inflammatory drugs, steroidal anti-inflammatory drugs, otherwise called steroids, and certain drugs which are very rarely used but nevertheless have a role in the treatment of gout, namely ACTH, adrenocorticotropic hormone, and interleukin-1 antibodies, like for example canakinumab. Now, the long-term management of gout involves the administration of urate-lowering therapy. To prevent the progression of acute gout to chronic tophaceous gout, we need to keep the uric acid levels within normal limits. If this can be achieved non-pharmacologically, that's great. But if that fails, then we need to add drugs which lower plasma uric acid. And this strategy is what we call urate-lowering therapy. Urate-lowering therapy involves drugs which are used to decrease uric acid production, increase uric acid excretion in the urine, what we call uricosuric drugs, and drugs which help the conversion of uric acid to allantoin. So this would be the uricase analogs. Drugs that decrease uric acid production include the xanthine oxidase inhibitors. So xanthine oxidase inhibitors include allopurinol and febuxostat. The uricosuric drugs, these include benzbrobanone, sulfenpyrazone, probenecid, and lesinurad. Uricase derivatives include drugs such as rasburicase and pegloticase. Now, urate-lowering therapy, once instituted, is best continued lifelong. But there are certain points to keep in mind when starting urate-lowering therapy. When urate-lowering therapy is started, irrespective of the agent used, the plasma uric acid level will fall. Now, when this happens, there is mobilization of preformed monosodium urate monohydrate crystals from tissue stores into the joints. And predictably, this could lead to precipitation of acute attacks of gout. We call these gout flares. Gout flares, if at all they happen, occur within the first 6 months of initiation of urate-lowering therapy. So, long-term control of hyperuricemia is necessary to prevent the progression of acute gout to chronic tophaceous gout. But then, urate-lowering therapy potentially precipitates acute attacks of gout. However, we always need to remember that gout flares, if at all gout flares occur due to urate-lowering therapy, they occur during the first 6 months of urate-lowering therapy. This explains why prophylaxis against acute gout flares needs to be instituted during the first 6 months of urate-lowering therapy. The drug most commonly used for this purpose is again colchicine. If patients are unable to tolerate colchicine, non-steroidal anti-inflammatory drugs may be used for prophylaxis of gout flares. Right. So, management of gout would involve management of acute gout using these drugs, and long-term management involves basically reduction of serum uric acid levels, and this may be achieved by urate-lowering therapy. And the thing to be noted during urate-lowering therapy is that during the first 6 months of urate-lowering therapy, co-administration of prophylaxis against gout flares needs to be given, and the drug most commonly given for this purpose is colchicine. We shall continue this discussion in the next video.